If your patient is crashing, blood pressure dropping, heart rate rising, skin changing, I need you to think shock. Hey everyone, welcome back to PCU Prep. I'm Marcus, and today we're breaking down shock, one of the most critical topics you need to recognize fast as a nurse. Because if you miss it, your patient can deteriorate quickly. But don't worry, I'm going to break this down in a way that actually makes sense. Stay with me. What is shock? All right, first things first. Shock is not just low blood pressure. Shock is when the body is not getting enough oxygen at the tissue level, meaning your organs are not being properly perfused. So even if the numbers don't look terrible yet, your patient can still be in shock, and that's why early recognition is everything. The 4 types of shock. Now let's break it down. There are 4 main types of shock you need to know: hypovolemic, cardiogenic, distributive, and obstructive. All right, let's break down the first 2 types. Hypovolemic shock means low volume. Your patient is losing fluid. Think bleeding, dehydration, vomiting, diarrhea. So there's not enough volume in the system to circulate. Now, cardiogenic shock, that's a pump problem. The heart is failing, usually after a massive MI. So the volume might be there, but the heart can't move it forward. Think of it like this: hypovolemic, empty tank; cardiogenic, broken pump. That one comparison will save you on exams. Now let's talk about distributive shock. This one is all about the vessels. The blood vessels become too relaxed, too dilated. So even though there's enough volume, it's not being properly distributed to the organs. The most common type? Septic shock. But this also includes anaphylactic shock and neurogenic shock. And here's your key clue. These patients are often warm and flushed early on. That's very different from the cool, clammy skin you see in other types of shock. Last type, obstructive shock. This is when something is physically blocking blood flow. Think pulmonary embolism, cardiac tamponade, tension pneumothorax. The heart might be working, but blood can't move the way it's supposed to. So your patient still ends up with poor perfusion. So quick recap: hypovolemic, low volume; cardiogenic, pump failure; distributive, vessels too relaxed; obstructive, flow blocked. If you remember that, you can answer most shock questions. Now let's talk about what shock actually looks like, because catching it early is everything. Early shock is when the body is trying to compensate. So what do you see? Increased heart rate, tachycardia, increased respiratory rate. The body is trying to get more oxygen in, cool, pale skin, because blood is being redirected to vital organs. And your patient might be anxious, restless, or confused. Now, late shock? This is when compensation starts to fail. Blood pressure drops. Mental status worsens, urine output decreases, and now you're heading toward organ failure. So don't wait for hypotension. By then, you're already behind. So what are you looking for as the nurse? First, vital signs. Rising heart rate is often the first clue. Second, mental status. If your patient suddenly becomes confused or restless, pay attention. Third, urine output. Less than 30 milliliters per hour? That's a red flag. And fourth, skin changes, cool and clammy, think hypovolemic or cardiogenic shock. Warm and flushed, think distributive shock, like sepsis. Your assessment tells you everything. Now let me tell you something that trips a lot of people up. Blood pressure can look normal in early shock. Because the body is compensating, it's working overtime to maintain perfusion. So if you're only watching the blood pressure, you can miss what's actually happening. That's why you have to look at the whole picture: heart rate, mental status, urine output, skin. All right, let's test your knowledge. A patient with severe dehydration presents with tachycardia, low blood pressure, and cool, clammy skin. What type of shock is this? A, cardiogenic; B, hypovolemic; C, distributive; D, obstructive. The answer is B, hypovolemic shock, because this patient has lost volume. And without enough volume, the body can't maintain perfusion. Practice question 2. Next question. A patient after a massive myocardial infarction develops hypotension, shortness of breath, and signs of poor perfusion. What type of shock should the nurse suspect? A, hypovolemic; B, cardiogenic; C, distributive; D, obstructive. The answer is B, cardiogenic shock, because the heart, the pump, is failing to move blood forward. Practice question 3. Last one. A patient with sepsis is warm, flushed, and hypotensive. What type of shock is this? A, hypovolemic; B, cardiogenic; C, distributive; D, obstructive. The answer is C, distributive shock, because the vessels are dilated and blood is not being properly distributed. Now let's talk treatment, because this gets tested all the time. First, oxygen. Always support oxygenation. Second, IV fluids, especially in hypovolemic and septic shock. Third, vasopressors. These help tighten the vessels and raise blood pressure. But here's the key. Treatment depends on the type of shock. You don't treat cardiogenic shock the same way you treat hypovolemic shock. So always ask yourself, what's the underlying problem? Quick rapid fire before we go. Shock. Poor tissue perfusion. Early signs, tachycardia, tachypnea, anxiety. Late signs, hypotension, decreased urine, altered mental status. Hypovolemic. Low volume, cardiogenic, pump failure, distributive, vessels dilated, obstructive, flow blocked. And remember, don't wait for the blood pressure to drop. Catch it early. And that's shock, simplified. If this topic ever felt overwhelming, I hope it finally makes sense now. Drop in the comments. Which type of shock confuses you the most? And if this helped you, like, subscribe, and share with a nursing friend.